My name's Andrew Haley. I'm a locality manager in the out-of-hospital division. Recently completed the CUSA course run by the Trust. It was during one of the sessions on demand and capacity that a colleague and I started to discuss about district nursing capacity. We were currently in a position of going into the COVID crisis and the anxieties around that. So using what we'd learned during the CUSA course, I came up with an idea of a demand and capacity tool for the district nursing teams. So I devised it on an Excel spreadsheet. It looked at nursing priorities within the community services, priority 1 visits for district nurses that were essential to patient care. We determined priority 2 visits, which were visits that potentially could have been stepped down. Within that, we looked at the staffing availability, and I came up with this demand and capacity tool that I presented to my GM and head of nursing. Fast forward 4 weeks, and using the PDSA methodology that again I learned from the CUSA course, we were able to develop a operationally functional tool that allowed us as a trust to respond to variations in workforce availability and increased demand in the service in light of the COVID response and the acute discharges that we had to deliver on. During the pandemic, we utilised it within the teams to identify hotspots within the teams and potential staffing issues that allowed us to respond and support the teams across the county. So it was North, Rugby and South. We also included a single report that was available for Gold Command as part of the emergency response, which allowed a single situation report that looked at capacity across the county, at place within the 3 areas, and also within each district nursing team, the 12 district nursing teams across the county. The tool evolved during that period again through the PDSA methodology, where we added in the Home First nursing and therapy teams as well. We added in the system beds, which again was reflective of our community hospital capacity, and also our blue beds that were procured at Myton and Ellen Badger for patients with COVID being discharged from the acute. We also added on there the limb restriction pathway, which was another jointly commissioned pathway with Warwickshire County Council that was piloted during this time, that we were looking at facilitating that support for patients to go home. This was all captured within the single sit rate report of the capacity tool. As we came out of COVID and we were part of the recovery and restoration process of the emergency response, the engagement and sustainability of the tool became evident because the teams are still using it, they're still utilising it, they see it of value, and currently from a Swift perspective, we plan to share it with foundation partners in Wye Valley and George Eliot, and also we've had conversations with NHSEI to look at developing the tool as a functional operational tool that perhaps can be utilised elsewhere within the country. So it's a positive, and it all came from a conversation following a session on the CUSA course in March, and back of a fag packet drawings.